risks are, there can be risks which are of things going wrong during the surgery. There are risks which are of things going wrong after the surgery. During the surgery, there can be a very, thing that we're scared of is support for the artificial lens may get damaged at times. So if we do not have enough support for the lens that we want to implant, we may have to go for an alternate type of lens. Which may not be, as the visual quality may not be as good as that of the lens that we wanted to implant. And that may make surgery more difficult. We may have to do some extra steps to create support for the lens. Then sometimes the lens fragments may fly off and go into and get themselves lodged in place which is difficult to reach. So we may have to do a different surgery from a different route to retrieve them also. These are things which can go wrong during the surgery. I'm talking about the important risk factors. I'm not about the minor ones, the major ones. After the surgery, the major risk factor is of infection. Though the occurrence of infection is only about 0.01 to 0.03% all over the world. And but yes, if it occurs in one patient, for him it is 100%. Because once the infection gets into the eye, then managing it becomes very difficult. Why? Because the drugs, whether taken orally, whether taken into the vein, or put into the as drops into the eye, they do not penetrate the eye deep inside. Because the eye is a very hard shell. It is secluded from the rest of the body circulation in a big way. So there is the barrier between the blood circulation and the eye. So that barrier, the drugs cannot cross that barrier. So the drugs don't reach into the depth of the eye. And that's what makes the management of infection inside the eye a little more tricky and difficult. Infection does get managed. However, it may leave behind scarring. And that affects the vision. So these are the most important and most risky big problems that we can. I'm joined with another colleague of mine, Dr. Parul Sharma. She's come all the way from Gurgaon, braving the rain.
It's a one-time shot only, this operation.
This is a one-time thing only.
The reason I'm asking you is,
Yes.
I know a friend of mine who got operated. Now his one side vision is almost like half of the other one.
Okay.
So he says this side is really getting bad.
Right.
So that is why I ask you, what is the success percentage in this sense?
The success in terms of vision and as a surgery, it is one of the most commonly done procedures, one of the most advanced and controlled procedures, and it is also one of the most successful procedures across medical science all over the world. So I would say, I think I may be right in saying that cataract surgery is the commonest surgery performed all over the world for the longest of time. And fortunately, cataract surgery was first performed in India by Sushruta. So we can proudly say that India was the first one to perform cataract surgery. And so from those ages, is evolving over a period of time. So it is one of the safest surgeries, one of the most successful surgeries. The results are as high as, as close to 100% as possible. So maybe only some percent of cases, the results you can say is not successful, but otherwise it is very successful surgery. It's a very safe and accurate surgery, and surprisingly very economical surgery also, compared to other surgeries that are done for say bones or heart or anything else.
Because we hear in newspaper now, they did some surgery for 100 people, 50 went blind and all this thing.
Yeah.
That may be
Okay, see, of course, the way you drive a car will define the safety of your vehicle also. So if somebody drives rash on the road, where one's supposed to drive very safely, so in present day times, I'm not in favor of those kind of camps. Camps are not really required now. With the facilities being advanced, hospitals being available everywhere, doing camps in the periphery in large scale is not really desirable. And when there's a cost cutting involved, now cost cutting happens in the form of these agencies who do camps, or the government agencies which hold camp, or charitable agencies. They have limited funds. They have limited funds. They have limited resources. But the output, they don't want to limit the output. They still want to do high numbers, high volume surgery because they want to get more funding from other. It is when you're pushing the quantity over the quality that things go wrong. So if a surgeon should ideally not perform too many surgeries in one day. After all, you're a human being, you have to get tired also. Resources are limited. So if I say in one set of equipment with one set of people in one location, if you do a large volume, especially in a new place which is not geared for anything, things are likely to go wrong. And then it's not just the eye surgery, other surgery have gone wrong also. There were media reports also. As a result of which, now the surgeries, peripheral surgeries, in the camp have been completely banned for last almost 10, 20 years. Now, surgery have to be performed in a hospital only. Though still there's no limit on the number of surgeries that should be performed in a day for a given resource. So I think the government may soon, give up some guidelines where the number of surgeries that can be performed in one day in one OT with a given set of people will also be limited. So
Also, mostly, I think the fluid is at fault. These surgeries which go massively wrong, there is some cost cutting in the fluid which we use, and that's mostly responsible for the large number of loss of eyes, which is like introducing infection into the eye, which is usually the case.
actually, that is what happens most of the time. I didn't want to say that, and that will be kind of trying to fix blame on a particular thing. Many a times the infection is not that something is introduced by a surgeon. So it is infection usually comes from the various solutions that are used to wash the eye during the surgery, medicines instilled, or from the OT environment also, and also many times from the patient's own skin. So, and these are the areas where the doctor may not have any control on, especially in a camp setting. That's why I said that when the cost cutting is done, when you want to do a high volume surgery at very low cost with limited resources, that's when the things are likely to go wrong. So when the solutions used are also cheaper. So coming back to your question, which got missed out, that in the second eye you had more pain. What happens is when the person goes for the first eye surgery, we are very scared. We afraid. We fear the worst. That will be very painful. There'll be injection. It'll not be very good. I may not be able to cooperate. And you find that no, there was no pain at all. Second time you are absolutely relaxed. You feel that nothing is going to happen. So, and then even the touch or slight pressure feels uncomfortable. This happens with a lot of patients. जैसे कि हाँ डॉक्टर साहब पहली बार तो हमने किया था बड़ा आराम से हो गया था कोई दर्द नहीं पता भी नहीं चलता ऑपरेशन हो गया है नेक्स्ट टाइम में बहुत पेन हुई है आपने वही ऑपरेशन किया जो पहले किया था
out of 100 patients हमारे probably 90 patients will say कि first time में pain नहीं हुआ था और second में pain हुआ out of 100
This is the reason.
90 people say that.
So now I've started doing is I telling the patient
I thought it would be the opposite.
And
Because first time you got the unexpected, second time you sort of know what is coming.
so it is if you expect the worst but you get it better. See what you're getting is this only. You were expecting this but you got this. Next time you're expecting this much, you got this much. So when you have to come down, you don't feel very good. Yes, yes sir.
I think. Thank you very much. As a layman, I understand what are the symptoms if there are cataract is there. Now the first decision is whether it should be macro insertion or the laser. Now you also mentioned that the laser is decidedly less dependent on doctor's skill, so it is considered to be better, but it may be expensive. So that decision patient has to take depending upon how much he has to invest and how much he believes the skill of the doctor.
Right.
That is what I understand.
Exactly.
Now second, you said that the type of lenses, there are 4 or 5 type of lenses. That is a discussion between the doctor and the patient. Now there can always be an error.
Yeah.
Now I can say the doctor has not advised correctly, or you can say that you have not told your requirement correctly. Is there any tool which can help the patient to decide the explicit difference between the 2 or 3 or 4 type of different options? Because when you talk and explain, I mean, as doctor mentioned that every eye is different, some eye adjust very fast. So is there any possibility of using that tool to take a reasoned decision rather than depending upon the discussions? That is one question. Secondly, the last decision a patient has to take, whether I should go to Max or I should go to a eye hospital who is doing only day in and day out only eye surgery. That's a question everybody will ask. So that comes to my mind. So I would like to know from you, as you mentioned that your Panchsheel has just started laser surgery, and there could be another eye hospital who is doing it for ages, and they've got its line of doctors and they are all having good proven track record. Why I should think of going to Max? Is it the cost benefit, or you have some other reason also?
Coming to the first question, that how to decide on the lens now. Broadly, there are 2 types of lenses, unifocal and multifocal. However, there is no objective tool to measure the suitability of a particular lens in a particular patient. Why? Because it all depends on the patient's visual requirements and needs and patient's expectations of the vision out of the surgery. So that is where it is a matter of discussion. You have to discuss, you have to explore, you have to do your own thinking also. That which is what will suit you the most. And what I strongly advise against is that I tell my colleagues also, and I myself follow that I never push any patient for any particular type of lens. Sometimes I push them away from high-end lenses when they expect too much, when the requirement is totally different. Then I dissuade them. I may dissuade them from multifocal and go for my unifocal, but I never push them into any particular direction. I leave the choice to the patient. Because after all, it is your own decision to go for. But yes, understanding the advantages and disadvantages of both the type of lenses, looking at your own requirements, what is your visual requirement? And then also one should you have to look at it from a very, very unprejudiced mind. Sometimes one person says, I don't want to wear glasses. I'm getting operation done, you're putting a lens inside the eye, I'm spending so much money, then why do I have to why should I need to wear the glasses? It is this point which at times brings about an imbalance in the judgment on the part of the doctor and the patient both. So that is where the discussion at times can go wrong, that when there's a pressure, okay, fine, I don't want to wear glasses.
But to be more technical also, apart from discussion, we can share with you the technical aspects of your eye. जो आप tools बोल रहे हैं, जैसे कुछ आईज में मल्टीफोकल डालने का कोई एडवांटेज ही नहीं है. सपोज आपका सिलेंड्रिकल एस्टिग्मेटिक नंबर हाई है, तो जो ब्लैक एंड वाइट आपके आई के पैरामीटर्स हैं, दैट वी कैन एक्चुअली शेयर विद यू. बिकॉज जब डिस्कशन एक अलग पार्ट है कि आपको क्या चाहिए, बट देयर बी सर्टेन ब्लैक एंड वाइट थिंग्स ऑफ योर आईज ओनली व्हिच कैन टेल अस कि आपकी आईज में ये लेंस बेटर है. तो मोनोफोकल है, एस्टिग्मेटिज्म है, मल्टीफोकल है, वो डेटा वी कैन शेयर विद यू कि आपकी आईज के ये पैरामीटर्स हैं और ये आपको सूट करेगा. हाँ बिल्कुल, मतलब या बिल्कुल.
Gross recommendations. Gross recommendation can be made. Okay, fine. That don't think of this lens. It may not be suitable. But that happens in extreme cases. But in average case, at times it may be difficult to decide. To the second question.
Also, it's the cost factor, so which will help you a lot.
Yeah, I know that is also there.
There's a
So
huge
the
cost
patient-
difference which usually decides for the patient.
So you
No,
have to
okay.
take a.
But I'm saying that let us not get into the cost factor also. We should put that as a secondary criteria. Think of that later on. First, look at the merits and demerits of the thing.
I mean, the
Come in
cost
as-
difference does not justify
Yeah, that much of.
that much
I
of
understand. Each
quality.
one has to
That
be-
is the
Quality.
catch.
If I have surplus money, I can go for the.
Yeah.
irrespective
Otherwise, the
of the cost.
difference
But
is
if I have
just
to
like he said,
see
only
these
please.
Yeah. No, it's not a question of having surplus money. It is, one should not think of the money part. Money comes secondly. Okay, then you should, okay, fine, this is the thing. Can I afford it or not? Maybe I can't afford it now. Maybe after 3 months, 6 months, I may have funds, and then I can ask the doctor whether I can wait for that long or not. Not may say, okay, fine, okay, wait for 3 months time. Okay, I'll come back after 3 months with more funds. So I would say that money part should be kept as second criteria. First, one should discuss the scientific aspect.
Right.
The second question, you said that the laser is recently installed at Mac. This laser has been installed only for 1 year in any other center.
I see.
This has come into India only for the last 1 year. And so it's not that, in fact, and I said that because less surgeon dependent, so it is kind of minimizing the value of a surgeon.
The learning
Okay.
skill is negligible
Why should
because we
one-
are all surgeons. We are
Why
used
should
to
one-
that technique.
Yeah, why should one go to a multi-specialty hospital versus
Yeah.
only eye hospital? There are again merits and demerits in both of them. In multi-specialty hospital, the support structure is much more elaborate. Most of the patients are, in the senior age category. They're older than 40, and they always have some what we call comorbidity. There are some other ailments which are there always there alongside, visible or hidden. There will be diabetes, there can be hypertension, there can be heart disease, there can be other factors also, which can also have bearing on the patient's general well-being. So from that point of view, getting a surgery done or treatment done in a multi-specialty hospital where other specialists and other industries available is an advantage. Now if you go to a separate standalone eye center, things may happen faster. They may be slightly cheaper because of maybe their turnover is faster. They don't need that kind of elaborate infrastructure. Their costs are lower, so that benefit is transmitted to the patient. However, because of the limited resources that they have and access to, there are at times cost cuttings at areas which are not visible to a common man.
And can I add, like, we are Max Eye Care, so it doesn't mean that we are not an eye center. We don't need to have a 3-floor building, but we have a similar or better equipments than any eye center. So we are a full-fledged eye department with all specialty covered under one roof. Secondly, we focus a lot on quality because we are not into quantity of doing 100 patients in certain time of days. So if you come and experience Max Eye Care, you know what I'm talking about, because each patient individually is dealt on a one-to-one person. We don't believe in having 20 patients waiting in the queue, and we have a very fixed appointment system. And these are all experienced and senior doctors who are doing only their specialist work. So we have somebody doing oculoplasty, squint, glaucoma, retina separately. So if you have a particular problem, then you will come and experience that actually इतना time spent होता है आपके one-to-one में. मतलब हमारा mainly OPD is second referrals because people go to eye centers, then they don't get satisfied sometimes. So हमारा main chunk of patient is who's been elsewhere, and then they come to us because they know that they will get a lot of one-to-one and extremely ethical and to the point analysis for you and treatment for you. Because it's not an eye center कि आप आओ जाओ और करा लो, which when you come you will experience that.
So see, we are a team of about 20 doctors, 20 eye surgeons in Panchsheel, and about 40-45 eye doctors across Max and Delhi NCR. So we are a very strong team of specialists from all across things. So it's not that there's anything missing. The laser that we have installed is one of the most advanced lasers. It's the first in the North India, and with one laser is capable of doing a lot of different varieties of surgery. So, but anyway, there can always be, you know, for and against things for both the kind of thing. It's always a difficult question to answer that whether to go for eye center or not.
And the other thing is, in smaller eye centers, they have like one person doing just the biometry, one person doing the investigations. So you have different hands. Here you'll probably there'll be one contact who's constantly monitoring, which is an advantage because that same person is actually overseeing every step of the procedure.
Okay, so any more question on
So
cataract
Dr.
part?
Sir,
Yes.
I want to ask one question. That after this cataract surgery, after how many days can you read newspapers and magazines? Dr. Amanjot is my doctor. I wanted to ask this question.
Actually, we can give you a temporary number even the next day. A temporary number can even be given the next day, and you can resume your activity. But sometimes sharpness takes a week or so.
So
As we said, the best corrected we judge by 3 weeks, but most people get good vision at 1 week where they can resume their normal activities.
Okay.
With a temporary number, a permanent number is given at 3 weeks if it's a unifocal lens. And with multifocal, as Sir said, the adjustment phase may vary from 1 week to 3 months and very rarely 6 months also.
And
In other words, there's no restriction of reading newspaper. You can read
Even
newspaper
though-
right from the next day. Maybe try with your old glasses.
Old glasses.
It may not be very sharp, may not be very, very clear, may not be very comfortable, but you can start from the next day
so
itself.
3 weeks we have to wait actually to start.
3 weeks is the final
Final,
refractive
right.
error when you can get your the good pair of expensive glasses if required. But for temporary one, you can get even the next day.
So, Dr. Saab, I presume all the operations on cataract are being done by laser now in your hospital?
We give it a choice to the patient. The advantage of the laser, as we said,
Yes, Dr. Saab has
is
explained, yes.
A little, but the cost difference is huge.
Mhm.
So we finally
Depends.
leave it to the patient,
Gotcha.
giving you the advantages and the flip sides. Yeah.
Thank you, Dr. Saab.
So the question here is that what would the evening haze and glare in with the multifocal lenses? Unfortunately, you have to just give the eyes time to adapt to that. So there's a lot of adaptation which takes place, and the neurological system is able to take care of that part.
3 months or 6 months.
Yeah, and
But
yeah.
beyond that, if this still continues.
you have to just take a precaution that don't drive very fast, drive slow, and
Even reading, for example.
so reading you have to use slightly brighter light. So if you're using a brighter light from above and left above your left shoulder, you may be able to read better rather than a diffracted light.
I thought I heard you, doctor, say that you need to put some
Eye drops.
Eye drops.
No, those eye drops don't really work. But the drops which are used to bring the make people smaller, they don't really help. They cause discomfort and cause dependence also. I would not recommend that. Yes, some adjustment in lighting and reading material. You may have to put the reading material slightly further away. So the correct reading distance, correct reading posture, use an inclined tabletop thing to put your reading material. Have a light coming from above and behind your left shoulder. It actually helps. So these are things which one should do. You have a question?
Doctor, in case the adaptation of the multifocal lens doesn't happen, after say 3 weeks or 3 months, then what's the next step?
I'm saying
नहीं, I mean हो जाता है.
this will be my answer. If in 3 months' time, 4 months' time, the adaptation has not happened, then it's a very, very difficult situation. You know, then we have faced a situation where we may have to think of, you know, removing the lens and implanting a unifocal lens.
Unifocal.
We try to reach the decision much earlier. If things are really so bad, you know, in a month's time, patient gets to know, we get to know. So in that rare circumstance, we may maybe decide on removing the lens and implanting a unifocal lens in those eyes, no. And but waiting for 3 months to do repeat surgery makes the surgery more difficult, because by then the lens may have become kind of fixed in its position, and removing it may become difficult, may cause damage to the support for the next lens to be implanted.
Mhm.
However, it is possible. If it is done, say, then in a month's time or so, it's very easy to remove that lens and
So
implant another lens.
By about a month's time, one comes to know
With
that
both- with
it's
both
not
eyes done,
adjusting that
in a few
well.
weeks' time, one gets to know. You know. If it's a minor deviation, then over a period of time, adjustment will happen. But
Okay.
if it is a gross problem, then of course one has to go for a change, and that we can get to know within a couple of weeks' time.
Friend of mine tries to solve this problem. He got one eye operated for distance and the other one for reading.
Yeah.
So he was able to get the best of both worlds.
Yeah. So this is what we call monovision. Yeah.
For people who can't afford multifocal या उनकी eyes fit नहीं है multifocal के लिए, for example, this is a very easy and practical solution. Even before multifocal, we were doing lot of something called as monovision. मोनोविजन का मतलब ये कि वन आई व्हेन वी डू कैटरेक्ट, आपका एक आई हमेशा डोमिनेंट होता है और एक नॉन डोमिनेंट होता है, एंड वी नो हाउ टू फाइंड इट आउट. तो जो आपका डोमिनेंट आई है उसमें हम लेंस डालते हैं जो आपको दूर का दिखाएगा, नॉर्मल यूनिफोकल लेंस, एंड ट्राई टू गेट यू 6x6. दूसरी आई में पास का मतलब क्या कि आपको प्लस का एडिशन चाहिए रीडिंग का. तो नॉर्मली सेज पे +2 2.5 होता है सबका नंबर. तो दूसरी आई में जब हम लेंस डालते हैं, बिकॉज पावर हमारे हाथ में है कैलकुलेट करना, तो हम आपको -2 बना देते हैं दूसरी आई में. तो एक आई आपका डिस्टेंट डोमिनेंट हो जाता है और दूसरा आई आपका नियर का हो जाता है, बिकॉज ऑफ दैट माइनस नंबर. एंड बिकॉज सो
That is the thing,
यूनिफोकल
yeah.
लेंसेज आल्सो यू बिकम फ्री फ्रॉम ग्लासेस. नहीं, वो हो जाता है, वो हम आपको पहले से दिखा भी सकते हैं आपके लेंसेज लगा के. अगर बहुत एडवांस कैटरेक्ट नहीं है तो वी गिव यू अ फील कि ऐसा होगा. और दोनों और कई लोगों का नेचुरली मोनोविजन होता है. आप बहुत सारे लोगों को देखेंगे 50-60 में आपके साथ पार्क में घूम रहे हैं और वो बोलेंगे आप मेरा तो पास का चश्मा ही नहीं आया. और उस वक्त अगर वो कोई योगा बाबा रामदेव और कुछ कर रहे होंगे या कोई ड्रॉप्स डाल रहे होंगे तो देखेंगे कि हम तो ये ड्रॉप्स डाल रहे हैं और हमारा पास का नंबर नहीं आया है, जबकि ऐसा बहुत रेयर होता है. उन लोगों का कैसा आइज है कि एक आई में थोड़ा सा माइनस है या एस्टिग्मेटिज्म है माइनस में, तो उसकी वजह से वो पास का भी पढ़ पा रहे हैं. तो दैट इज नेचुरली बिकॉज ऑफ द नंबर्स. तो आप नंबर्स के साथ प्ले करके यू कैन गिव बोथ डिस्टेंस एंड नियर, व्हिच पीपल हैव नेचुरली आल्सो, एंड उनका आइज एडजस्ट कर जाता है. सो वो हो जाता है. दैट्स नॉट एन इशू.
Again, it's not the ideal thing. It's not the ideal thing. It is not fit for all things. Yes, it can. You know, it fits some people very well. As she said, that some people have naturally different power in the two eyes. If you naturally have different power in the two eyes, say one eye is different from the other eye by more than 1 or 2 diopters, so you're naturally tuned to that imbalance. But if both your eyes have got exactly the same power, then it is less likely that you will find it suitable. However, yes, a trial can be done beforehand, and that can be done in the form of glasses of different powers.
The eye can actually tolerate a difference of up to 6 before it gets double vision, scientifically proven. So 2 is not such a big deal for most people. It can be, it's not a...
Doctor, if there is some lazy eye, can it be improved?
The lazy eye, or which is also called amblyopia, is the condition where, despite putting the glasses and despite everything else being all right, the vision is not 100%. So effectively, the resolution of the eye has got arrested at a lower level. That is what we call the lazy eye. This usually happens before the age of 9 years in a child, if there are things wrong with the eyes, and can be easily corrected before the age of 9 years. However, after the age of 9 to 13 years, that is when the visual system of the eye becomes fixed. It's more difficult to treat. However, some slight improvement in laziness can happen even later in life also, by correcting the refractive error, by correcting the thing which is causing the problem. But yes, it becomes more difficult, and the improvement is less in a later year. Before the age of 9 to 13 years in a child, where the visual system is very flexible, moldable and developing, it can happen much better.
Actually, doctor, I was about 22, 23 years that time.
Yeah.
when I came to know that my right eye is the lazy eye. So I asked the doctor, Dr. Madan Mohan was there in AIMS now, Professor Madan Mohan. So he told me that it's a lazy eye. So only some improvement will be there. I got it operated in 2001. And I'm not using specs because I'm working as a contractor. I don't require those things. I got both my eyes operated, second in 2008. And I don't feel any problem in reading, far seeing and other things. Shall I use the specs?
No, if you're comfortable, then why should you use the specs? You don't have to.
Because I feel very uncomfortable when I use those.
No, if you're very comfortable with this, without the specs,
Yeah.
there's no strain, there's no difficulty in seeing things.
Okay.
There's no reason for specs. Spectacles are required for two reasons. When there's a blurring of vision to see clearly, when there's a strain or discomfort to make feel comfortable. If you're not experiencing any of these two problems, then there's no need for specs.
Sometimes I feel in reading.
Even if the number is there,
Yeah.
even if the number is there, but you're not facing any of this difficulty, you don't need to wear specs. And nothing will go wrong with your eyes if you don't wear specs. So don't worry about that.
Because sometimes I feel when that sixth line is there
Yeah.
in your that booklet,
Yeah.
sometimes I feel there's some problem.
So maybe
In last.
maybe if you're reading very fine print, you can use glasses. Other
Okay.
times you can stay without.
Okay, thank you.
So the next topic is glaucoma. What is glaucoma? It's a condition, where the pressure inside the eye rises and can cause damage to the nerve of the eye, what is called the optic nerve of the eye. It's a potentially blinding condition. So it's a very serious condition, it's far more serious than cataract. It is fortunately much less common than cataract, however, common enough to be worried about. The normal pressure on average ranges from about 10 to 20 or 11 to 21, 22. 22 to 26 is taken as a borderline. More than 26 is grossly high. But this is this is average kind of thing. Sometimes it's possible to have glaucoma with lesser pressure also. Let us not worry about that. So in simple terms, glaucoma is a condition where the pressure rises and can cause damage to the nerve of the eye, and which can lead to blindness. However, unfortunately, in the beginning, the vision is not affected. There's no pain, there's no discomfort, there's no symptom in the early part. And it starts simply dimming the vision in the periphery. And the dimness becomes deeper and starts enlarging. Much later, the central vision is affected. So as a result of which, when there are no symptoms, there's no visual problem, it goes undetected in many cases. So it gets detected much later, or on a routine eye examination times. So what are the symptoms? Mostly, there are no symptoms. Sometimes pain, blurring of vision, colored rings around can happen in some type of glaucoma, but mostly again, there is no symptom at all. Restricted field of vision, peripheral visual field defect, are noticed by the patient much later. So it's actually very, very important for people to undergo routine or regular eye examination after the age of, let us say, 40. So typically in glaucoma, it is the peripheral vision which gets dimmed out, center remains quite all right. So how is it diagnosed now? As I said, it's mostly picked up in a routine preventive eye examination. What we do is we first check the pressure of the eye, what is also called the IOP or the intraocular pressure. We check the thickness of cornea to see whether these pressure measurements are accurate or not. We do something called gonioscopy, or looking at the angle of the eye. Now, inside the eye, there is a fluid which is called aqueous humor. It circulates, it forms in one part, comes out through the pupil, goes out, gets drained out through the angle. So it circulates inside the eye. If the angle is defective, from where it gets filtered out, that can also lead to increased collection of fluid in the eye, increase in the pressure. So we have to look at the angle by doing gonioscopy. We check the periphery of the vision by what is called visual fields examination or perimetry. We look at the optic nerve fibers by a scanning test called OCT or optical coherence tomography. So these are the 4 or 5 tests done to reach the diagnosis of glaucoma. They're more technical. Then once glaucoma is diagnosed, its severity is established, the damage done is established, then we have to think of the treatment part. Treatment is usually in 3 forms now. 3 things, 3 tools are used in the treatment: drugs, lasers,